worrying about getting through too many cases. So good evening, everyone. As you're joining us, good to see you.
Like as usual, shall we just wait for it for 2-3 more minutes?
Yeah,
Nathan, is that all right?
I think
Because
that's
people are still joining. Just 2 more minutes, maybe 2-3 minutes.
I think that's great. How are things in Northern Province this week? Anybody have any in terms of the COVID situation and other situations?
Yeah, in Mullaitivu area, the cases are drastically dropped. But fortunately, we had the lockdown last week, and it has been it is over from 1st of last week, 1st of October. So I don't know what will happen in future. In next week, we are expecting the next week what is the outcome of this lockdown and how it progress, whether it is in the positive side or the negative side.
Mm-hmm.
I have been functioning as the COVID focal point in Vavuniya district. So what happened was in the month of September, we had totally 130 deaths. That's a huge number. If we consider 100,000 population at risk, that will be 67 deaths per 100,000 population. And we had significantly high number of admissions, and around 80% of them, the admissions were oxygen dependent. So that's a lot of late presentation, and we had a lot of death. But after the October started, or by the end of September, the cases start to reduce significantly. But now the lockdown was there till the 1st of October. Now they have removed it. I don't know whether we will have another small peak or something. We'll wait and see.
How is the vaccination process happening there? Is it?
I think in our district, more than 80% vaccinated first doses, and second dose also I think nearly 70% or more vaccinated. The reason for the delay in second dose is a lot of people got infected. So the infected people supposed to be waiting for a month to receive their second dose. So that is causing a small delay there. Otherwise, it's going on.
And what the primary vaccine that you have access to there, is it the Sinovac, or which is the main one you're using?
It is Sinopharm for the community.
Okay.
Yeah, for the most of the healthcare worker, we had this Indian version of AstraZeneca, the Covishield.
Oh yeah.
And currently we are having the vaccination program for the younger age group from 12 years to 19 years, the children with comorbidities or disabilities. For them, they are administering Pfizer.
Okay.
Okay. And in Northern Province, Mannar district, they had most of the population vaccinated with Pfizer.
Okay. Helpful to just get a sense of where things are at.
This is Suren. I think it's a good sign now. Then maybe things will improve with the vaccine, and also so we can plan maybe after a month. We need to have so we can have a separate meeting later.
Yeah.
So now it's almost more than 80% of the population is covered. The first dose and second dose also more than 70%.
That's great. Yeah. Well, we can probably get started now,
with the session. Yeah.
Yes. Yeah. I just
sorry,
wanted to take.
I have another meeting at 8:30 with this University of Liverpool, so I will leave.
No problem. I just wanted to take a moment as we start just to acknowledge Dr. Balin, who I understand died very suddenly, and I did not know him well, but we just wanted to take a couple of minutes of remembrance and silence for him. Does anybody have any that knew him, any remarks or memories about him or thoughts?
Yes, we have known him from 2000, I think 17. That day we had a program to train the ambulance drivers and the paramedics regarding this, basic life support program. So we used to go to each and every district and do the program. So in Mannar district, I think Dr. Shakti Balan was the coordinator at that time. So myself and Dr. Puviharan, he also were trained here. And we went there and we had a nice welcome there. And he's such a nice person, always respect other human being and always welcoming us. And we can anytime call him and ask any help. So it's such a great loss for us.
Very sad. Any other thoughts from anybody else?
Same remarks I want to make, and he's such a nice and wonderful person, but I don't have any kind of close contact or relationship, but that I usually meet him in the meetings and thing, and that's what I know him. Yeah, but I heard about him a lot. So it's a great, sad to hear that such a young doctor. Right.
He was only 40 years old, and I believe he had a heart attack and died suddenly. Is that right?
Yeah, as far as I heard, that thing happened.
Right. I mean, I just want to do a quick reflection on our health. I mean, we know the doctors and nurses are the worst patients. I just wanted to ask myself, I mean, including myself, when was the last time we checked our own blood pressure? When was the last time we did our own lipids or cholesterol or HbA1c? When is the last time we saw our doctors? We need to ask questions. We don't want to lose any end, especially the South Asian genetics. We are very high risk for coronary artery disease. So please remember, doctors, nurses, we are the so bad patients. So check your blood pressure regularly. Check your blood, see your doctor. Check your lipids, and if you need to take a statin or a blood pressure medication or diabetes control, please take your health seriously and add to the stress of the medical profession, and especially in Sri Lanka, we are very high risk. So that's, I mean, my reflection today.
Thank you, sir. So I think we'll start a session today, because we have to carry on with our session. Many of the participants are waiting. And remember, Dr. Sakthibalan will always be in our prayers, and please do convey our deep condolences to their family members. So good evening, one and all. So I request all the participants to kindly please turn on your video cameras. And I think most of you have renamed. Sorry, please keep your video camera turned on throughout the session, and your attendance is very important for us. And I request, I mean, do you want me to directly introduce Dr. Mathurahan, sir, or is there something like Dr. Jonathan or Dr. Vara? You have something to convey to the group?
Sure, I can introduce him. Yeah. So probably many of you know Dr. Mathurahan. He's been very involved in the palliative care program in Northern Province for the last several years. He primarily works in Vavinia, and I think he is a man of many trades and hats in terms of medicine, and is very, very busy, often in cardiology and now in COVID, and but also has had a very keen interest in palliative care. And he attended the resident training program in Hyderabad and has come back to, along with Gaushigan in Talipale, to really help get some palliative care programs initiated. So he will be an ongoing, very helpful resource for this group as other people start up their own clinical work in other districts. So he's here today to talk about some cases that he's encountered in Vavinia and some of the challenges they've encountered there. So over to you, Mathurahan.
Thank you very much, Dr. Jonathan. I will start from this point onwards. I think 2018, from September first week to October second week, for a period of 6 weeks, we had a nice time and a very good training program, very well planned and executed, and we learned from hospital care, home-based care, and the hospice-based care from the Hyderabad team. That is really inspiring and motivating thing, and also we gained a lot of knowledge which we didn't had before. So that is the starting point for me personally in this palliative care program. But if we consider the Vavuniya district, few years back there was a OMF surgeon, I should remember him always, named Dr. Ranjan Mallavarachi. He started a palliative care unit and he trained few staff, and with the limited resources he did home visit as well. But when he got the transfer, that program dropped in the midway. But we are still utilizing some of his trained nurses and other staff for the palliative care services. So from that point onwards, I would like to go through a few of the photos we have taken when we started the service. I think a home-based care service we started from 2019 January onwards. So far, we have seen more than 240 cases, and last 6 months were horrible for us because of this COVID. We had significant reduction in the number of referrals. And also another part, even with the COVID crisis, we were doing the home visits up to a point where we had a lot of patients, so family members becoming positive. And after the visit only, we got to know that they became positive retrospective. That means last week we went to a patient, and the next week they are calling and informing us that their whole family became positive, so be careful. So at that point, we had to limit our services only to the hospital-based care. So we are planning to gradually restart the home-based care from this month onwards. Okay, then we'll go to the case. Next slide. So these are few photos to show the level of care we have provided. Not only providing medicines, we had to give full support. We had to change the catheters. We had to provide the patients regarding this bed sore care, prevention of bed sores, and other wound care and other psychosocial support as well. The next slide. So this is our both of the nursing officers are managing a patient who is bedridden to do the wound dressing for bed sore. Next slide. So this is in one of the very remote villages in Vavuniya. The patient unable to travel to the hospital to get any medications. Even his family members were reluctant to travel because of their economic considerations. So even they didn't have a decent house. So we had to make him seated outside, and we had to see the patient. So this is our team. Okay, next slide. So today's discussion case, it's a 64-year-old female, mother of 3 children, 1 son and 2 daughters. 1 son and 1 daughter got married and they are living separately. And youngest daughter is single and she is the main caregiver. And also they are getting the support of her aunt as well. And they are living in a village called Mathurahan, Vavuniya. And her husband passed away a few years back due to MI. And their main financial support is from the son who is living separately. Next. So this is the patient. Next slide. So 2 years back, she was healthy with no chronic medical problem, and she developed a progressive dysphagia. Investigated in Vavuniya District General Hospital. During endoscopy, found to have a growth in the esophagus and biopsy done. and histologically diagnosed as squamous cell carcinoma of the esophagus. And she had lymphadenopathy on the time of diagnosis, and also it's decided as inoperable and given 13 fractions of radiotherapy, and it was not responding, and the patient also refused to continue further. So at that point, referred to us by consultant oncologist. Next slide. So when we attended the patient for the first time, she was only in liquid diet, and also with that she had a significant loss of appetite. She had abdominal pain with a pain score of 3 out of 10. She was bedridden with limited mobilization. Only for toilet she was mobilizing, and she had a bed sore as well. Next slide. Okay. So in examination, we found to have the patient was ill-looking, wasted appearance. She can speak but sounded depressed, and she had very poor insight about the disease prognosis. She was thinking that she is having an illness that will cure after a while, and she can do her work up to the normal level after she is getting cured from the disease. And she had a tender epigastrium, and other systems were normal. Next slide. So the plan of management, we discussed with the consultant oncologist Vaunia and plan to give a short course of dexamethasone 8 mg daily for 5 days to address the dysphagia mainly, and also as a part of care for the loss of appetite. And we prescribed tramadol 50 mg for the pain relief, and the bedside care was explained to the caretaker, and we did visit once in 2 weeks, and we started to counsel the family members regarding the patient's condition. Next. So the initial response, her appetite picked up a bit. Family understood her prognosis and the role of our team in the second counseling session, but they didn't want the patient to learn about this, and the patient was in denial with hope of miraculous cure, and the pain was responding with tramadol SOS, and she complained loss of sleep in the second visit, and we have prescribed a small dose of amitriptyline night times to tackle with the loss of sleep, and also to treat the mild depression she was having, and it responded well. Next slide. So the first challenge we had to break the collision. So the patient was in denial, and the family now got to learn about the outcome, but even though they didn't want us to tell the patient about the disease or the prognosis. So with series of counseling, we explained to the family members that she is in denial, so she might have a lot of things to do, and she might be interested in doing some of her advanced rituals. That means planning her deeds or something, and speaking with relatives, and getting down her children who are living in other districts. So like that, she may be having a lot of last wishes. So we explained to the family they should give her a chance to get those done. And after the understanding, she wanted her excuse me. And we also explained to the family that our team's part is not to cure the patient's condition, but to comfort her problems, whatever she is experiencing. So after a lot of counseling, they understood the role of our team, and they agreed to convey the patient regarding the disease progression and the outcome. So we eventually broke the bad news to the patient, and with it, as we explained to them, she wanted to do a lot of things, and she wanted her youngest daughter to get married before her death. So they fixed a proposal, I think within 1 month period, and arranged a simple register marriage in front of the mother 1 month prior to her death. So next slide. The second challenge was feeding. with the progression of the disease, we had to deal with the progression of dysphagia. We suggested NG feeds, but even though the family members are okay with it, the patient strongly refused, even after a lot of counseling. With respect to her decision, we couldn't do much after that. But as her pain score came up to 5 out of 10, occasionally we started her on oral morphine 10 milligram 4-hourly dose. Initially, the family was reluctant and complaining as her, as she's weak and having a lot of problem, we are prescribing too much of medicines to her. But later they understood the concept and started to give regular morphine, because main issue they are worried is giving medicine 4-hourly, and they try to omit some of the midway doses. So even though he is having some pain reduction at the beginning, he will not receive a dose in 4 hours. So the pain will come again. So it will be fluctuating. So she did not have complete pain relief in the beginning, but after we discussed with the family and made them understand about that, they agreed to give the regular dose. And also we suggested try it for 1 or 2 days. If you don't feel comfortable, we can change. So they tried and it made her comfortable. So they started to continue. Next slide. Third challenge, end of life care. This is in 2020, the third week of June. The condition became worse. Her activity significantly reduced. She complained about burning sensation all over the body, and oral feeding became almost nil. And also we had to, as the oral feeding is almost nil, we couldn't give the tablets. So we needed some other methods of pain relief. So we decided to convert to the fentanyl patches. Initially, we had some challenges to give the fentanyl patches to the home care patients, because that is a controlled medicine. The fentanyl patches, IV morphine, those kind of medicines are controlled medicine, which usually they allow to prescribe only to the inward patients. But there is a special form with the recommendation of consultant oncologist. We got the approval from our hospital director, and we prescribed the patient with the fentanyl patches. We had a training session to the family member how to attach the patch and how often they have to change, and even after attaching the patch, how long they have to continue the the morphine in the possible way. So these kind of things we explained to the family. But as she couldn't take orally, she couldn't take anything orally, we had our nursing officer went to the patient's home twice, and we administered subcutaneous morphine for 2 days, 2 doses actually. So after that, the patient was on fentanyl patch. Next slide. So the problem is, while we still working on the process of getting the fentanyl patch, that is not the first dose. The second one, the patient passed away. The main technical problem we had at that time was, first dose we could get immediately from the consultant sign and director sign, and we could give them directly. But the second one that fell in a weekend. So we also couldn't plan that in the advanced way, and we had some technical problem getting both the consultant signature and director signature and getting the medicine from the pharmacy. So during that struggle, the patient also passed away. So the next Monday we couldn't give the medicine. So what I wanted to explain here is, lot of technical problems are there while administering the opioids. The oral morphine, of course, currently we are having no difficulties and we are prescribing, and also to give the home-based care patients initial few doses we are giving from the donated morphine, that whenever a patient dies, we are getting the balance morphine back to our unit, and we are storing in a cupboard and locking it. Only myself and our nursing officer having access to it. So while going to the home visit, if we supposed to, or if we had to start oral morphine to any patient, usually we are doing the home visits on weekends. So till the Monday, we used to give the oral morphine to the patient and comes back. So Monday, one of the relative of the patient will come to the hospital and get the balance of the medicine. But for this IV morphine and the fentanyl patch, we have some technical issues. That's what I wanted to mention here. Next slide. So fourth challenge, after death care. The patient passed away on a Tuesday around 2:30 p.m. I was working in cardiology unit with a consultant. Nursing officer started duty at 2 p.m. and he visited the patient's home by 10:30 and administered the second dose of morphine, as I can remember. He already clearly explained about the terminal stage situation to the whole family, but they wanted us to come and confirm the death. But we couldn't immediately go as we both of us are employed, in some other units. But and I think they tried to call our nursing officer. He also was on duty and he wouldn't answer the call immediately. So they brought her remains to the hospital. So I think currently, because of the COVID situation, each and every home that they are bringing to the hospital to confirm whether it's a COVID case or not. But at that time, we didn't have that kind of arrangement. So after coming to the hospital, it will be considered as an OPD death. So sometimes depends on the OPD doctor who is attending, they might write for the inquest also. So it will take a lot of time to get the remains cleared for the funeral arrangement. So that is another challenge we had, because this case we did in the beginning or initial part of our journey when we started the palliative care service in Vavonia. So we also didn't have that much of experience regarding this matter. So I think we caused trouble to the family because they brought the remains to the hospital and they had to wait for a few hours to get the body released from there. So whenever there's a patient, terminal ill patient in the end of life care, I would recommend we should explain the family clearly that this is the course of events going to happen, and if they have a peaceful death at home, usually I'm not considering this COVID situation. Usually, what they can do is, as that is expected matter, they don't have to bring the body to the hospital. They can inform to the local person, GS, and with the permission of GS, they can plan the funeral arrangements, because that is, they already have a diagnosis, and we are already expected to have a terminal period within few days. Okay. Next slide. So before going to the second case, if anybody have any discussion or any concerns or any questions regarding the first case, we can go through.
That's great. Thanks, Mathurahan. Does anybody have any thoughts or comments on that case, either in English, or if you would prefer to speak in Tamil, please feel free to speak in Tamil and ask questions in Tamil. And most people, except maybe me and Vanilla, will be able to understand.
Yeah, here he have given the morphine 4 hours. So I think it's is it practical? I mean, for the family members. So hello.
You are asking whether it is practical to give tablet 4 hourly?
Yeah. I mean, will they give? I mean, the family members will give continue or not? I mean, because every 4 hours it is very difficult, right?
Yes, but usually what we do is we used to write them the exact time. We don't just write 4 hourly. We have a usual formula what we learned in Hyderabad. We used to start from 6 a.m. in the morning. So 6 a.m., 10 a.m., 2 p.m., 6 p.m. and 10 p.m. we used to ask them to give double dose. So they don't have to wake up the patient at 2 a.m. So that is the formula we used to give. Even though initially we had some problem, after explaining it to the family members and from their experience, because they also after a few days, they will feel the patient is having significant pain relief when they are giving the tablet regularly. So from both point we can achieve. But if there is a stable patient, what we usually do is, after the pain is significantly controlled, and if the patient is stable, we used to convert it to a slow release tablet. So we can give a BD dose with SOS, immediate release tablet. So that is a possibility. But We have
They
slow
are
release
slow.
tablet.
That's
Yes,
fine.
we have. In Vavani Hospital, we have slow release and immediate release. So that is a good option in stable patient. But in a patient who is, rapidly deteriorating, we don't want to change the usual way because that may cause, problem to the patient if the pain is not settled or if they don't give in a proper way.
Why can't we add, I mean, in compare, why can't we use in combination, I mean, slow release whenever in SOS basis?
Yes, that is the usual way. When we are converting from intermediate release to the slow release, we have to first calculate the total requirement of the morphine per day. Then we have to divide that and give in a BD dose, and we must give immediate release tablet in SOS base. So in every clinic, we have to reassess whether they needed that immediate release tablet in between. So if they regularly in need of that immediate release tablet, that means our dose is not adequate. We have to increase the dose.
Okay, thank you.
Dr. Mathurahan, in Canada, when our practice, we have something called expected death package. That means நாங்கள் ஒரு ஃபைல்ல வந்து we have நிறைய forms எல்லாம் வச்சிருக்கிறோம். So what happens is we will actually be talking to the patient and the family and saying what is there to expect from now till the death and even after the death. So once the patient is struggling, he has to call the numbers. எல்லாம் வந்து அதிலேயே வந்து ஒரு ஃபார்ம்ஸ்ல எழுதி வச்சிருப்பினோம். And இங்க வந்து funeral home. So patient செத்தா பிறகு the nurse comes and certify the death or the doctor goes and certify the death. அதுக்கு பிறகு அந்த ஃபார்மின் படி they will inform the nursing home and they don't take the body to the hospital. அந்த மாதிரி ஏதாவது ஒரு எக்ஸ்பெக்டட் டெத் பேக்கேஜ் மாதிரி ஏதாவது இருக்குதா ஸ்ரீலங்கால?
யூனிவர்சலா ஒன்றும் இல்ல, பட் சில விஷயங்கள் அட்ரஸ் பண்ணப்படுது. உதாரணமா நாங்கள் மெயினா டெவலப் பண்ணின ஒரு விஷயம் வந்து நிறைய பேஷண்ட்ஸ் வந்து பேஷண்ட் க்ளோசர் டு த டெத் சஃபரிங் பார்த்து டெத் ரச்சல் வரும் அந்த டைம்ல வந்து உடனே பேஷண்ட எமர்ஜென்சி யூனிட்டுக்கு கொண்டு வந்து அட்மிட் பண்ற ஒரு கல்ச்சர் வந்து இனிஷியலா இருந்தது. ஸோ அட் ஒன் பாயிண்ட் வி நாங்கள் டிசைட் பண்ண என்னன்னா எங்களோட கேர்ல இருக்கிற பேஷண்ட் ஒருத்தரும் எமர்ஜென்சி யூனிட்டுக்கு வந்தா அது எங்களோட ஃபெயிலியரா தான் நாங்கள் பார்க்கணும். யாராவது எமர்ஜென்சி யூனிட்டுக்கு கொண்டு வரணும்டா அதால நாங்கள் அதை வந்து கவனமா கவுன்சிலிங் கொடுத்து பேஷண்ட்டையும் ஃபேமிலிட்டையும் முதல்ல இன்ஃபார்ம் பண்ணி ஒரு கன்சென்டம் எடுத்துடுறது. நாங்கள் வந்து க்ளோசர் டு த டெத் எங்களுக்கு எந்த ஒரு அட்வான்ஸ் லைஃப் சப்போர்ட் ட்ரீட்மெண்ட்டும் தேவையில்லைன்றத ஒரு நாங்கள் ஒரு ஈவன் தோ தட் இஸ் நாட் லீகல் இன் ஸ்ரீலங்கா நாங்கள் ஒரு அண்டர்ஸ்டாண்டிங்ல ஒரு கன்சென்ட் மாதிரி எடுத்து நாங்கள் எங்களோட அவைய கிளினிக் காப்பியில டாக்குமெண்ட் பண்ணிடுறோம். அந்த ஒரு விஷயம் நாங்கள் செய்யறோம். அடுத்தது வந்து நான் கிளியரா எக்ஸ்பிளைன் பண்றது வந்து இந்த ரிமைன்ஸை நீங்க ஹாஸ்பிட்டலுக்கு கொண்டு வர தேவையில்லை. ஏன்னா இது வந்து ஒரு எக்ஸ்பெக்டட் கோஸ் ஆஃப் த இல்னஸ். அதான நீங்க வீட்டிலேயே வச்சு ஜிஎஸ்க்கு இன்ஃபார்ம் பண்ணிக்கல அவையில வந்து ஆல்ரெடி நான் குரோனிக் இல்னஸ் உள்ள ஒரு ஆளுண்டா ஃபர்தரா இன்கொஸ்டோ வரணும் செய்ய தவிர ஃபியூனரலுக்கு கேரி அவுட் பண்ணலாம். மற்ற அரேஞ்ச்மெண்ட் வந்து இப்ப இங்க வந்து பொதுவா ஃபியூனரல் ஹோம்ஸ்ல செய்யற கல்ச்சர்னு பவுனியால இல்ல. அதனால மற்ற அரேஞ்ச்மெண்ட்ஸ் வந்து பொதுவா இங்க இல்லைன்னு தான் நான் நினைக்கிறேன்.
அந்த மாதிரி ஒரு எக்ஸ்பெக்டட் டெத் பேக்கேஜ் வந்து நாங்கள் நார்தர்ன் ப்ராவின்ஸுக்கோ இல்ல ஸ்ரீலங்காக்கோ டெவலப் பண்ற மாதிரி ஒரு அட்வொகசி பண்ணலாம்னு நினைக்கிறேன். I think it's time இல்லையா? Do you agree?
Yes.
I think in the working group we can actually develop we will talk with Jonathan and we can get ideas from other places and tuning to the local needs and the procedures. I think it's a great idea to develop something called அங்க வந்து ஒரு ஃபைல் தான் அதுல வந்து முதல்ல போட்டிருக்கு do not call 911. அதான் அந்த ஃபைல் இந்த டாபிக் மேல அந்த ஃபைல் எடுத்தோம்னா நாங்கள் எல்லா பாலியேட்டிவ் கேர் வீட்லயும் அந்த ஃபைல் இருக்கு. அப்ப அந்த கடைசி நேரத்துல பேனிக் ஆகுறது எமர்ஜென்சி கொண்டு வரது எல்லாம் இல்லாம we will actually I think it's a great idea to have that developed in Sri Lanka.
இன்னும் ஸ்ரீலங்கால இப்ப எங்கட ரூரல் ஏரியால உள்ள பிலீஃப் என்னண்டா பேஷண்ட்டுக்கு ஒரு இல்னஸ் இருக்குண்டா அவர் இறக்க வேண்டிய இடம் வந்து ஹாஸ்பிட்டல் தான் என்று சொல்லி ஒரு அசைக்க முடியாத நம்பிக்கை கொண்டு இருக்கு. அவையில வீட்டுல வச்சு ஒரு பீஸ்ஃபுல்லான டெத்தை கொடுக்கறது அவைண்ட சைட்டத்தோட நாங்க கன்வின்ஸ் பண்ணினா கூட இந்த சரௌண்ட் சுத்தி இருக்கிறார்கள் அயலவர்கள் சொந்தக்காரர்கள் வேற மாவட்டத்துல வேறவர்கள் எல்லாம் வந்து இதுல பிளேம் பண்ணுவீனம் என்ற ஒரு பயத்துல எப்படியாவது கடைசி நேரத்துல ஹாஸ்பிட்டல்ல கொண்டு போய் நாங்கள் ட்ரை பண்ணாங்க ஒன்னும் செய்யலாம் போயிட்டுன்னு சொல்லி ஒரு முடிக்கிற ஒரு கல்ச்சர் தான் இங்க இருக்குது. அதை அட்ரஸ் பண்றதுதான் ஒரு சரியான சேலஞ்சிங்கான விஷயம். அதை வந்து நாங்கள் நிறைய கவுன்சிலிங் தேவைப்பட்டது. நாங்கள் எமர்ஜென்சி யூனிட்டுக்கு பேஷண்ட்டை கொண்டு போகணும்ன்றது எஸ்டாப்ளிஷ் பண்றது. அப்ப அதுக்கு பிறகு நாங்கள் என்ன செய்யறோம், ருட்டீனா வந்து ஒரு டிசீஸ் பற்றின அண்டர்ஸ்டாண்டிங் நாங்கள் கவுன்சிலிங் பேஷண்ட் கொண்டுட்டோம்டா as soon as possible வந்து நாங்கள் டாபிக்கை தொட்டுருவோம். உங்களுக்கு வந்து இப்படி ஒரு சுச்சுவேஷன் வரும், அந்த டைம்ல வந்து அட்வான்ஸ் லைஃப் சப்போர்ட் தேவையா இல்லையான்னு.
Perfect. Great discussion, Mathurahan.
Can I say my input? Is it okay?
Yes.
I'm Dr. Khan. Yeah. In our culture, now what I feel is somewhat a little bit of a different opinion. What is the problem is in foreign setup, they have the nursing care. In your nursing homes, the nurses will go and assess at any time, and they are a little bit trained for that. But in our setup, the problem is if the patient started a death rattle, and it is quite disgusting for the patient. And our people are usually mainly in the rural areas. They are living as a it's not a nucleated family. It is very extended family. So the children, everybody will get afraid, and those stuff will happen. And for the red rattles, and they couldn't able to give top up morphine, so they can't do anything unless you are giving an IV drug. The IV drug giving at home is, and there is no sort of a syringe drivers here to be given at the home also. So what I advise to my patients is, if you are getting bad, come and I can give a full end of life care at the hospital. Because I am a little bit more comfortable in giving at hospital, because that will be a full extent of end of life care. We can give it with satisfaction. The problem is at home, they will be given for a short time, and at one point patient can't take oral, and then started the rattles, and then they can't give any hyoscine or bascofen or anything, nothing. They can't increase the morphine, then they will be afraid on that. And there is no 24-hour service to contact a doctor throughout to give some support in the middle of the night. So what I do for my practice is I ask them to admit to the hospital for end of life care if they really want. But if the patient is not willing and I want to die at home, yes, that's fine. I can support to my maximum extent. The only problem is, like this case, we can't give a IV morphine at home. And then what will happen is, if we're supposed to give some more drugs, and if or else somebody getting as a out of the way, if we are giving it, and somebody thought it's a patient is struggling and giving some more drug, and if somebody complaining this is a suspected of homicide, then there might be go for a postmortem. So there are some legal issues on that. So we can't go out of the way also in this aspect. But fentanyl, I am discharging with fentanyl patches, taking their own risk, and then getting the books, and then writing and signing and giving it. But only thing is, for end of life care, I am not much comfortable at our setup, because if the family members are just put it in the room and lock the room, the patient will struggle at the last part of the life. What I feel from my point of view is, just struggling 4 hours of severe pain and not supported by anybody, can't able to get up, is really a terrible event, whether I have lived the life or not in the past. So the patient or myself will feel like that. So that's why I for our setup, I usually ask them to come to the hospital for end of life care. What is your suggestion, Jonathan and Dr. Varamadu?
Nisargan, great input. I know you are very practical. Anal, our side, Dr. Mathurahan and Dr. Kausigan, we've been successfully doing the end of life care at home. It's I know what you're saying is correct. We can do much more at the hospital, but these hospital beds are very precious. And, that's the reason we want to more develop the palliative care, the community-based palliative care. And I think Dr. Mathurahan, and you're right. I mean, whoever really wants to come to the hospital, yes, they will be brought. But we have to offer them what is available, and then they choose, I think. What do you say, Dr. Mathurahan?
Because the way we were trained in Hyderabad and here under your guidance and Dr. Jonathan's guidance, And also from the personal experience, we feel most of the patients, 99% of the patients want to spend their last minutes at their house. And they want their loved ones to stand surrounding them. And that thing we want to respect. And another problem we had when they mobilize the patient to the hospital, there will be some elements of, hope for the miraculous care. And eventually, at one point, sometimes they may intubate and put in the ICU also. That happened to a few cases. So they will spend in the 1 week in the ICU, and the same expected course may be extended. That's what we are afraid. But only challenge is actually we have to visit the patient frequently when they are, in the end of life, when we are giving the end of life care. So we did that actually, because even though we supposed to do this, home visit every weekend, when there's a patient closer to the death, myself and our nursing officer in our personal vehicles, we used to go and see the patient frequently. And of course, there are some issues with the, I think already we discussed that about in our previous case discussions also, in that IV morphine. I think Jonathan also used to mention that undercover morphine. So we took some risk and we actually got a permission. I don't know how legally sound that, but we got a permission from the oncologist and the director, and we could administer some subcutaneous morphine for the patient. And also we had to comfort the patient at the last moment. I accept Mathurahan sir's comments also, but for a certain extent, I think we were able to achieve that. And we also stayed with few patients also during the closer to the period of death. So in another point of view, I think we can gradually develop the facilities to support the end of life care in the homes. We need competent staff actually. Our nursing officers are actually well trained, and with 2 years of experience, they also can detect the the terminal period, and they will immediately convey the message, and the possible ways they also knows to support, and they also know how to support the family and how to do the end of life counseling to the family members, and other part also they are competent. So by the I think series of training and experience, we can gradually go to that ideal part. Otherwise, we have to develop a hospice in each and every district. So the concept of hospice will be achieved throughout the community, and they will know that it's not a place to cure the patient, that is a place to support the patient. So if they bring the patient to a hospice, we will happily accept and provide the end of life care. That's my point.
Yeah, I do agree. That's the ideal way. The only challenging was the regular visits is the problem. The area where I was working is Mullaitivu, and now it's a base hospital Kites. So it's only around 4 islands you have to travel through the sea actually.
That's very difficult.
Yeah. So the doctor's visit is it's very difficult. Even I started once a month clinic of a normal route in my medical clinic. It's quite difficult to go and then covering the both things, and the doctor shortage is also still there. So it is a little bit of at the moment why I do is it's a little bit impractical, but I do agree that if we develop the facilities, and if there is a sort of a IV drugs can be given at home, which can be changed over 48 hours, then that will be the ideal. And another point of thing is now in this case, even after a huge amount of counseling over months and months, they finally brought the remains to the hospital. So that means the relatives, some of them are not happy. So that's the take-home thing we can take it, because even after the death, everybody knows that if you call the Grama Seva, they will come and confirm the death, and they will give the cause of death also. But if they are not convincing with what we are saying, then they will go for a second opinion. And what I do is in my clinic book, I will write it not for intubation in a red pen. So then the doctors who are seeing never go for intubation, and only for full-blown medical conservative treatment. So like that, I will write it, and only for palliation. On the front side, I will write it in a red pen. So then it's a very rare chance to go for intubation, because nowadays beds are very precious, and ICU people are intubating a cancer patient is quite rare nowadays, because they will try to search for the finding how to avoid that, because if the bed is blocked, then they will be in trouble. So I think that's the way at the moment going, but ideally, yes, we have to develop the home-based care or else on a hospice or whatever it is. So in Mullaitivu, when I'm working, I have a separate room, isolation room for that, and I allow that 2 or 3 of them even to stay overnight, the relative to stay overnight when I'm giving end-of-life care. And there is no restriction for them to visit to the hospital. I know in the foreign countries, after 11 o'clock only you can just visit, and there is restriction after 5. In Australia, it's like that. After 11 only, they will allow to see the patient, or else you have to get a permission. So in our hospital, if you give a permission that if you allow them, ask them to allow, then they will give a permission. So most of the people can come and see it, and even overnight, I allow them to 2 or 3 people to stay and next to them. So that's how I practice. But ideally, there should be a lack of resources is the main thing. The doctors and now say Mathurahan is working as cardiology, and then this stuff, and then it's quite the setup is. If 2-3 patients at the time started to call, then it's quite difficult to manage to visit, and they might expect to visit and give us a guidance and give the drugs. So I think gradually it will develop probably. Or before my retirement, it will develop. Okay, thank you.
So there is one more question in the chat box, Dr. Mathurahan. The question is from Dr. Shobika. She asked, what about the legal documents in case of home deaths? Is a certificate of death given?
Yeah, that's, I think Mathurahan sir answered that question. In case of home death, if they inform to the Grama Sevaka, that's the local authorities person here in Sri Lanka, they will issue a death certificate with the cause of death.
Thank you, sir.
Doctor.
Hello.
Yes, sir, go ahead.
Yeah, subcut morphine வந்து home based careக்கு கொண்டு போய் கொடுக்கிறதுக்கு எல்லாம் பண்ணுவாங்களா?
இல்ல, அதான் லீகலா அதுக்குரிய ப்ரொவிஷன்ஸ் இல்ல. உண்மையா இன்வோர்ட் பேஷண்ட்ஸ்க்கு மட்டும் தான் கொடுக்கலாம். பட் இதுல வந்து இந்த ஓபியோட் யூசேஜ் பத்தின ஒரு டாக்குமெண்ட் ஒன்று இருக்கு. நான் வந்து அது ஷேர் பண்ணி வரேன். அதுல வந்து சில ஸ்பெஷல் சர்க்கம்ஸ்டன்ஸ்ல நீங்கள் வந்து ஃபென்டனில் பச்சும் இந்த சப்கட் மோர்ஃபினும் வந்து ரிலவென்ட் கன்சல்டன்ட் பெர்மிஷன், அதுல வந்து உண்மையா ரெஸ்பான்சிபிலிட்டி எடுக்கிற வந்து கன்சல்டன்ட். கன்சல்டன்ட் டைரக்ட் சூப்பர்விஷன்ல நடக்குதுன்னு சொல்லி கன்சல்டன்ட் பெர்மிஷன் டைரக்டர் அப்ரூவலோட வந்து நீங்கள் அதை கொடுக்கக்கூடிய பாசிபிலிட்டி இருக்கு. பட் எங்கட ப்ராக்டிக்கல் எமர்ஜென்சி சிச்சுவேஷன்ல சரியான கஷ்டம். ஏன்னா சில வேளை ஒரு பேஷண்ட்டுக்கு உடனடியாக கொடுக்க வேண்டிய மருந்து நீங்க 2 பேர்ட்டையும் சைன் எடுத்துக்கொண்டு ஸ்டோர்ல அதை கலெக்ட் பண்ணி கொண்டு போறதுக்கு அந்த இதுல சான்ஸ் குறைவு. அப்ப ஸ்ட்ரைட் ஃபார்வர்டா கொடுக்கல அதுமே.
வளமையா வந்து சப்கட் மோர்ஃபின் ஒரு ஆளுக்கு கொடுக்க போறோம்னு சொன்னால் வந்து ஹாஸ்பிட்டல்ல அட்மினிஸ்ட்ரேஷனுக்கு பிறகுதான் கொடுக்கலாம் என்றதானே கன்சல்டன்ட் மேட்ச் சொல்றாங்க. நாங்க லவ் பண்ண மாட்டோம்.
இலங்கையில வந்து அந்த இருக்கிற எங்கட டேஞ்சரஸ் ட்ரக் ஆர்டினன்ஸின் படி ஐவி ஓபியோய்ட்ஸ் ஒன்றுமே வந்து நாங்கள் ஹாஸ்பிட்டலுக்கு வழியில கொடுக்கல. பட் அந்த இதுல ஒரு ஸ்பெஷல் ஃபார்ம் ஒன்று இருக்குது. சில எக்ஸெப்ஷன்ஸ் கொடுத்திருக்கணும். அது வந்து நீங்க லிமிடெட் டோசஸை வந்து இன்கேஸ் ஆஃப் எமர்ஜென்சி கன்சல்டன்ட் சிக்னேச்சரையும் டைரக்டர் சிக்னேச்சரையும் எடுத்துட்டு அதோட வந்து நீங்கள் ஃபாலோ பண்ணலாம். உண்மையா அந்த எங்கட அந்த டேஞ்சரஸ் ட்ரக் ஆர்டினன்ஸின் படி எங்கட ஃபென்டனில் பட்ச் கூட நீங்கள் ஒரு இன்பேஷண்டே கொடுக்கறதுக்குரிய ப்ரொவிஷன்ஸ் தான் அதுல இருக்கு. பட் கிராஜுவலா அது வந்து இப்படியான ஒரு சர்டிபிகேஷனுக்கால கொடுப்படுது. இன்னும் சப்கட் மோர்ஃபின் வந்து ரூட்டீனா கொடுக்கக்கூடிய ஒரு பாசிபிலிட்டி இல்லை எங்கள்கிட்ட. அது வந்து கிராஜுவலா அந்த ரூல்ஸ் வந்து மாறும் நினைக்குது.
2 இயர்ஸ்க்கு முதல்ல டாக்டர் மதுராகனும் கௌசிகனும் துவங்கிட்டு டாக்டர் மதுராகன் தான் இதை அட்வொகேட் பண்ணி அதுல ஒரு சின்ன ஒரு கிரே ஏரியா இருக்குது. அதை யூஸ் பண்ணி அந்த ஒரு ஃபார்மை வச்சு சைன் பண்ணி போட்டு எடுத்துக்கொண்டு போனவர் நினைக்கிறேன் இல்லையா டாக்டர் மதுராகன்? அது டாக்டர் கேதிஸ் ஆல்சோ ஹெல்ப் அந்த இதுக்கு. ஆனா இப்ப we have to advocate for these practical things slowly. நாங்கள் எல்லாரும் தான் செய்யணும் அது. So these are baby steps we are taking, small steps.
Yeah, great questions and great discussion. just getting back a little bit to thinking about home deaths and some of the factors involved with that, all really good points around difficulty of resources and certainly not wanting to leave family members or patients at home suffering without the ability to give medications. I think there's a lot of factors that go into whether a home death is best for patients. I think, as was discussed, most patients will want to die at home. Even in Canada, we know that's true, but unfortunately, many people do end up actually dying in the hospital. Even I think in Canada, probably around half of deaths occur in the hospital. But we certainly aim for as home deaths to be more and more common. Hospices are, we often think of hospices as kind of the middle ground between hospitals and home, where it kind of provides some of the medical supports of hospital in terms of nurses and doctors and some access to medications. But it's a little bit more of a home-like comfortable setting than the institutional hospital environment. The big challenge with home care, as was mentioned, is just the resource aspect, because having nurses and physicians going out to individually see every patient at home is quite human resource intense. So figuring out how to support that is challenging. The big factor too with home deaths is the patient and family factors themselves. Some patients, there'll be relatively few symptoms and they have an incredibly supportive, capable family to help with their nursing care needs, and they probably can be well supported in a home death. For patients that have much more complicated symptoms to manage, some people do need to be in a hospital setting for end of life. So there's a lot of factors that go into those decisions, and part of it's talking with the patient and part of it's understanding their individual circumstances and then understanding the resources available. But I think all that we've talked about in terms of trying to move forward with making more resources available to support people at home would be very helpful. And overall, from a system perspective, usually trying to help people be able to die comfortably outside of the hospital does save the system resources on the whole, because hospital beds are in precious supply usually. Any other thoughts or comments about anything to do with this case? It's been a lot to talk about. Please, there's a message. Please send the form for using morphine in home visit. So I don't know, Mathurahan, is that something that can be distributed, or is that something that is different for each district? Or
no, that's general our central government circular. I will share the circular so they can go through the rules and regulations and everything, and clearly mention in what circumstances the form can be used and who should approve that and through which channel we should get the permissions. Everything is in that circular, so I will share that. I will share in that WhatsApp group.
okay, that's great. And so that's the form for just using morphine in general at home, or the form for using the subcutaneous morphine?
No, that is for the subcutaneous morphine and the fentanyl patches.
Yeah, okay, that's good. Yeah, I think with the subcutaneous morphine, that's really helpful to be able to have access to at home. In many countries, as Dr. Nisahan's referred to, people do have kind of continuous syringe drivers where they're given continuous infusions of medications at end of life. That's not always necessary in terms of people can get medications more intermittently, depending on what the medication is, like every 4 to 8 hours, depending on if it's opioids or antipsychotics or things like that. So they can have subcutaneous sites that if medications are available to family members, then they can be taught how to administer them too. So not necessary for the nurse to necessarily be there for 4 to 6 times a day, which is not practical. But I also realize there's, as was mentioned, other legal and maybe optics or public optics challenges for family members administering opioids at home to their loved one at end of life, and ensuring that there's no suspicion around whether that was hastening death or anything like that. So I think certainly those are just things to continue to work towards in the general policies of health authorities. So let me just see a couple other questions here. Do you get requests from families for giving IV fluids as patients cannot eat towards end of life, especially in patients with cancer of the esophagus? Any
Yes, always,
comments on that?
always we
Yeah.
are receiving a request to give IV fluid, but we are only giving when they are dehydrated. When we feel the patient's dehydrated and any, vomiting or any other reason. Otherwise, we used to convince the family member that IV fluids are just, a form of water, so they can simply take that orally. So that is superior than giving the IV fluid. That will be, trouble to them at this part of life, and we used to explain. But definitely, I think 90% of the family members request us for something, they expect us to give something intravenously.
It sounded like in this case, it was almost the opposite, where you were offering feeding tubes and more nutrition and the patient didn't want it. So that's interesting too.
That is, little bit earlier we felt the patient was stable at that point.
Yeah.
So we thought the main reason is the esophageal lesion. So we can support the patient with the NG tube, so we can continue the medications with the NG feeding.
Yeah, no, that's
so
very reasonable. That esophageal cancers or head and neck cancers certainly are one of the types of cancers where feeding tubes can be quite helpful, because patients can become very malnourished disproportionately to the extent of their disease. So we often are offering those in those situations. But in terms of IV fluids right at the end of life, we did have some conversation about that in some previous sessions. And as Dr. Mathurahan said, unless they're really showing signs of dehydration or that they might have some symptomatic improvement from fluids, or say they're having some signs of opioid toxicity or something like that, and you feel like you want to try to flush out some of the metabolites and help them feel better, tend to not use a lot of IV fluids right at the end of life, as it can contribute to more respiratory secretions and edema and things like that. So, but again, you can navigate that with the individual family. And
one more question from the foreign consultants. I do have the same experience when I work in Australia. The same thing, they ask for IV fluid for the inpatients, not for the outpatients, the inpatients. So, so what they are my consultant, and what we usually suggest is, if they are on end of life, we explain that it's really not necessary, and then we go for a risk feeding. If their family is happy, explaining there, maybe aspirate and go for a risk feeding. So what's the practice in Canada about risk feeding, and what's the practice in Canada about if the patient is inpatient requesting an IV fluid, and you are after explaining and they are confronting with you that they want some sort of a fluid or nutritious support, either form of a glucose or saline. So how you tackle, depending on case by case, you give it, or just you are rigid on not necessary?
Yeah, I think it's very case by case. If there's some small possibility that the patient may have some benefit from it and they're really wanting it, or the family is really wanting it, and I don't think there's going to be significant harm from it, then certainly we would offer it and see how it goes. Some patients, they may develop a really bad bowel obstruction, for example, and IV fluids can be quite life prolonging and supportive even for a period of weeks, even if they're not able to take significant amounts of oral intake. For some cultures, dying with IV fluids running is a very important thing, and it provides a sense of completion for the family that they've done all that they can right up until the end of life. And if it's not causing extra secretions or symptoms or things like that, then I usually, we can keep it running just at a very, very low rate. But generally for people that are very imminently near end of life, in the last hours to days of life, we would strongly recommend not having IV fluids running, as I have seen cases where it's, I think, contributed to more respiratory distress and swelling at the end of life. And the vast majority of cases, it's clear and families are accepting of that. So if I'm concerned about with a patient or family, then I usually just say, we can try this, but if we see signs that it's causing problems, we will stop it, and that will be that. And they're usually pretty accepting of that. So
I think here comes the communication and trust and the good dialogue with the family members and the patient. Jonathan is a consultant palliative care physician, but I'm a family physician. So I have a little bit of advantage because I know these patients throughout my career. They are in my practice. I'm blessed to live in a small community. It's like Vaunia பெரிய இடம் நான் இருக்கிற இடத்தை விட. அப்ப பேஷண்ட் முதல்ல பாலியேட்டிவ் கேர் துவங்க முதலே நாங்கள் முழுக்க எக்ஸ்பிளைன் பண்ணிடுவோம். அண்ட் பேஷண்ட் எங்களை ட்ரஸ்ட் பண்ணுவீங்க. டாக்டர் சொன்னா சரியா தான் இருக்கும். இங்கேயும் அந்த பிரச்சனைன்னு சொல்லக்கூடாது, அந்த ஒரு எதிர்பார்ப்பு இருக்கும். என்ன ஐவி ஃப்ளூயிட் கூட கொடுக்காமல் விவரிச்சாக விடணுமோ, பட்டினி கிடக்க விடணுமோன்ற மாதிரி. ஆனால் அதுக்கு தான் இட்ஸ் வெரி இம்பார்ட்டன்ட் டு பில்ட் த ட்ரஸ்ட் பிட்வீன் அவர் டாக்டர் அண்ட் த பேஷண்ட்ஸ் and the families. And சிலவேளை ஒரு family member இன்னைக்கு ஒரு கேள்வி கேட்பினா, tomorrow they will repeat the same question because there will be somebody, a daughter would have flown from Australia. Then we are happy to, that's what we are doctors. And this is what we call as the patient-centered medicine. We take our time and do it. So it's, I think, initially building the trust and the communication and dialogue, that is very important for a nurse or a doctor. I think we always try to do it. It's a very difficult thing, but that's what we are given, that position of a physician. So கஷ்டம் பார்க்காமல் கொஞ்சம் படிவா செய்தா நல்லா இருக்கும்னு நினைக்கிறேன். இன்னொரு இன்ட்ரெஸ்டிங் திங் டாக்டர் நிசாகன் said about the visiting hours. I know ஸ்ரீலங்காவில் கனடாவில் I don't think we have visiting hours. யாரும் எந்த நேரம் போய் பார்க்கலாம். இப்போ இந்த கோவிடால there are restrictions. Otherwise, there are no visiting hours. நாங்கள் எங்களுக்கு பிடிச்ச மணி நேரம் எந்த பேஷண்ட்டையும் போய் பார்க்கலாம். Of course, there are restrictions. இந்த ஐசியூக்குள்ள போயிடாது. இரவு 12 மணிக்கு போய் நான் அப்பாவை பார்க்க போறேன்டா சிலவளை விடுவாங்க. நீங்க இப்ப ஏர்போர்ட்ல இருந்து. பட் அந்த விசிட்டிங் ஹவர்ஸ் போட்டு பார்வை நேரம் I don't think we have in Canada. Is it in British Columbia, Jonathan, in the hospitals? Do they have visiting hours?
There are visiting hours for most patients in the hospital. For patients in palliative care, we have the most liberal policies, so there's not really visiting hours in palliative care. We are kind of limited to certain numbers of family members at one time, depending on the size of the room and the wards and all that kind of stuff. But we've been the most liberal with visiting as much as possible for palliative care. So. And just one last point I didn't mention, sorry, you asked about the eating at risk piece too. Certainly we have patients eating at risk at the end of life with the known risk of aspiration. And usually we talk to them beforehand about, if there was a sign of a significant aspiration event, how we would manage that with medications to help comfort and breathing, and not doing more chest x-rays and investigations and things like that, and just managing it more symptomatically. And that certainly it can happen quickly. So, but it is an acceptable risk if patients are wanting to eat at risk, for sure.
I mean, in a nutshell, there are no rigid rules in palliative care.
Yeah.
I mean, last week, one of my patients, he was dying of something, but last few days, he wanted to have nice single malt Scotch whiskey. So we said, go ahead. He enjoyed his Scotch, and he passed away peacefully. So no rigid rules. You don't say, oh, no alcohol, no smoking. No, this is, I mean, end of life care. So I mean, this is an example.
Well, great discussion today, everyone. We're just a little bit past the time here. So thanks so much, everybody, for joining and contributing. And thanks, Mathurahan, for presenting your case. We definitely had enough to talk about with just the one case. So that's great.
I think we'll keep a rain check on his other
Yeah, there you
patient.
go.
Yeah. Mathurahan, இன்னொரு நாள் உங்களோட மெட்ட கேஸ் நீங்கள் பிரசன்ட் பண்ணுவீங்களான்னு எதிர்பார்க்கிறோம்.
Sure.
Okay.
If there are no questions, I mean, are there any questions, or are we going to wind up the session, sir?
I'm just mindful of people's time, but yeah, if there's other questions, we're happy to keep chatting, but.
Yeah. I think there are no questions. I think we'll just wind up the session. Thank you so much,
Okay.
Dr. Mathurahan, for a wonderful guest presentation. And thank you so much for all the moderators for having this excellent discussion for this case presentation. And I have shared the feedback link in the chat box, requesting all the participants to kindly share your feedback using the given link. And we are going to see you within a week. We are going to see you within a week's time. And we'll be meeting you on next Wednesday, October 13th. And we already have case presenters ready for our sessions. It's Mr. S. Thamayantan and it's Kulan. Sorry, I'm so sorry. I'm not able to pronounce it properly.
Mr. Kurandai Yesu.
Okay. Mr. Kulan Tejiyasu. Okay.
Kurandai is a child and Yesu is Jesus. So
okay.
Child Jesus, that's the name.
Wow, not to be missed.
Yeah. Thank you so much. So sorry that I'm not able to pronounce your name properly, sir. So, and we'll all see you next Wednesday, 13th October, and at 8 p.m. sharp. Thank you so much. And please do not forget to share your valuable feedback. Thank you once again.
Okay.
Thank
Bye-bye,
you.
everyone.